Burn. Burn is a type of the coagulative necrosis that is caused by heat. Various types of burn on the basis of the cause could be thermal burn, electrical burn, radiational burn, or chemical burn. The various types of burns on the basis of the depth or the surface area involved could be first degree burn, second degree burn, and third degree burn. First degree burns are those in which only the epidermis is involved. There is the mild erythema and it gets healed within 3 to 5 days without formation of any eschar or formation of any hypertrophic scar. Second degree burn, there is the various degree of the dermis involvement, and it leads to the formation of the blisters, and which are very painful condition, and it get healed within 10 to 20 days with the formation of the hypertrophic scar. Third degree burn, the entire depth of epidermis and the dermis got involved. There is a formation of the tough dry eschar, and this is a painless condition, and it gets healed within 3 to 5 days, but there is a requirement of the skin grafting. As far as the emergency of the burns is concerned, for the emergency care, if the patient is exposed to the smoky fire, then the 100% of the oxygen is given by a non-rebreathing mask, and if the patient is unconscious, then endotracheal intubation should be performed. IV lines are secured, and there is an administration of ringal lactate at the rate of 1 liter per hour in the adult patients. Then the patient is transported in the warm and the clean sheath to the hospital. All the jewelry and the clothing are removed because there is soon development of the edema. Management of the burn patient in the hospital. First we will do the first aid thing, that we will give a cold bath to the patient. It would bring down the body temperature. Then we will take a brief history about the cause of the burn and the what was the mechanism of the burn. Then assessment of the depth of the burn. Next we will assess the extent of the burn, that is the area of the body which got under burn, with the rule of Wallace, also called as the rule of 9. Then we will do the charting of the temperature, pulse, BP, urine input and output. Then we will put the Foley's catheter. Next, the Ryle's tube is passed, as patient can develop the curdling ulcers. To prevent the bleeding in the stomach, cold saline wash is done so that there wouldn't be any bleeding. Antacids and H2 blockers such as ranitidine at the dose of the 150 mg BD is given. Replacement of the fluid volume in the burned patient is usually managed with the help of Parkland's formula, that is 4 ml of the ringal lactate into percentage of the burn into weight of the patient. So this amount of the fluid has to be given within the 24 hours. So the total fluid is divided into 3 parts. 1/2 of the fluid, 1/4 of the fluid, and 1/4 of the fluid. 1/2 of the fluid is given in the first 8 hours. Next, 1/4 of the portion is given in the next 8 hours, and further 1/4 of the portion is given in the further 8 hours. This is at the last we will also give the broad spectrum antibiotics to prevent any kind of infection. Next, acute abdomen definition. Patient complains of the acute attack of the abdominal pain that may occur suddenly or over the course of few to several hours. Most common complaints of the patient are pain in the abdominal region, nausea, vomiting, and alteration of the micturition habits, alteration of the bowel habits. The most common causes of acute abdomen could be intra-abdominal or extra-abdominal. Intra-abdominal could be acute appendicitis, acute cholecystitis, perforation of the peptic ulcer. There could be the biliary colic or ureteric colic. In the female patients, the torsion of the ovaries and the rupture of the ectopic are the very common causes of acute abdomen. Extra-abdominal causes could be the thoracic causes, for example, pericarditis, spontaneous pneumothorax, or retroperitoneal causes. Management. First, we will try to stabilize the patient. Next, a brief history is taken to try to analyze that what could be the further diagnosis. Examination is performed to clinch the diagnosis, and investigations are performed, for example, X-ray, USG, CT scan, in order to confirm the diagnosis. Then according to the diagnosis we have made, we will further plan the management of the patient. Next is a snake bite. The very first thing we need to do in the case of a snake bite is reassurance of the victim. because the most common cause of death is due to the panic the patient gets. Next, we are supposed to immobilize the limb, that is to block the superficial lymphatics. Then we are supposed to, if we are in the field setup, then we are supposed to take the patient to the hospital. Now, when we will take the patient to the hospital, meanwhile we have to analyze the signs and symptoms, and that would be morely based upon the type of the snake that has bitten the patient. So in India, mainly there are two types of the snakes, that is the neurotoxic and the hemotoxic. Neurotoxic are the cobra and the krait, and hemotoxics are the Russell viper, saw scale viper. So the anti-snake venom, which is the polyvalent anti-snake venom, which is available in our country, is helpful against cobra, krait, Russell viper and saw scale viper. So basic management would be the same. First, we will try to stabilize the airway of the patient, then the breathing, then the circulation part, and then we will carefully monitor all the vital parameters of the patient. For example, temperature, pulse, BP, respiratory rate. Then we will switch to local examination of the bitten side. So we can find the classical Fang marks, which is most commonly seen in a poisonous snake. That is two dots which are separated by approximately half centimeters. But in the case of the krait bite, the Fang marks cannot be visible. Then we are supposed to look for any blisters or any swelling of the limb or local lymphadenopathy, because these all are the signs of envenomation, that is the snake has injected the venom inside our body. Then we will perform the systemic examination. So if the snake was neurotoxic, then in the case of neurotoxic snake bite, patient would complain of the diplopia, ptosis, respiratory muscle failure or respiratory arrest. Then in the case of the hemotoxic bite, we can very first see the bleeding at the site of the injection. For example, if we have taken some blood sample, then it would continue to bleed. And we can also see the conjunctival hemorrhage and gum hemorrhage. So for the investigation, we are supposed to do 20-minute whole blood count. So in this, what we will do, that we will take the blood sample in a clean small jar, and then we will put the blood inside the small jar and we will keep it aside. Now if the clotting is present, that means the clotting is normal. If the clotting is absent, it indicates the disseminated intravascular coagulation. Other examination which we need to perform are CBC, urine routine, RFT, potassium and creatine kinase. Now anti-snake venom, that is approximately we are supposed to give the 5 to 10 vials of the anti-snake venom at the rate of 1 to 2 ml per minute. Then other prophylaxis, for example, tetanus prophylaxis has to be given, and antibiotics, example penicillin, amoxicillin, keep the patient under observation for around 24 hours. Adrenaline in case of the anaphylaxis, and if patient goes into the respiratory failure, then intubation and mechanical ventilation, followed by injection glycopyrrolate of 0.25 mg dose, followed by injection neostigmine, IV infusion. In the case of the renal failure, we are supposed to do the hemodialysis of the patient.